Hi everyone, welcome to my channel. My name is Yana. I'm one of the registered nurses. Currently I work for Queensland Health in Metro North area. In particular, it's a public hospital in a general medicine ward. If you have been on my channel for some time, you probably know my nursing journey, but if you are new here, big welcome. I assume you are either a nursing student or maybe a grad, so I hope my content will be useful for you. In today's video, I want to talk about comparison between AM, PM and night shift. I want to discuss ratios, penalty rates, which shift you can earn a little bit more, and also want to talk about tasks that you will be performing as a nurse in between all these shifts. I want to make this video more visual, so I'll try to put like 3 columns on the screen for you, and we will type in as I go so you can listen to me and also watch. So let's talk about times. When do you start these 3 shifts? So if you're working in a public sector, then your morning shift will be starting at 7 o'clock and then ending at 3:30. Your PM shift will be starting at 2:30 and then ending at 11 o'clock at night. If you work in night, then you will be starting at 11 o'clock at night and ending at 7. So 7 will be your handover, but you will be going home by 7:30 or 7:15 whenever you will finish your handover. Roughly, we're talking about here 8-hour shifts. If you do work in emergency, for example, or ICU or any other acute areas, you might be performing 12-hour shifts, so then your times will differ. Then let's talk about ratios. So in your morning shift in a public sector, you will have a ratio of 8 patients per 2 nurses. If we are short staff and we don't have a float, then usually takes some amount of patients from my ward where I work, then some of the group of nurses will have 9 patients per 2 nurse. So that kind of like 9th one will be shared between 2 of them, because usually what we do, we share 4 patients for each nurse, but then we do like DD checks together, we do movement, any manual handling of the patients, any change of dressing, continence aids, and all of this together with your body nurse or your partner nurse. But when it comes to normal medication administration, which doesn't require any checks, then you will be performing it to your 4 patients. Like your OBS as well, you will be doing it by yourself to your allocated 4 patients. So that would be your load in the morning. On your PM shift would be exactly the same load. And again, if we are short on a floater nurse, then you might end up having 9 patients per 2 nurses. If you are on a night shift, then it's a different story. On a night shift, the ratios are a little bit different. On my ward, we have 6 patients per 1 nurse. If we are like really short staff, then we would have 7 patients per 1 nurse, and then we will have an AAN with us at night. That will be helping us a little bit like with manual handling, you know, and pad changing and all of that. If you are in different wards, like for example, I have recorded for you guys a video of my night shift in palliative care unit. I'll try to leave the link for it in the description box below, or I might just put it in the end of the video as a clickable link for you to watch. So in that ward, in palliative care unit, the ratios are totally different to my ward. There they only have 3 nurses at night, which is your 2 regular nurses and then 1 TL, which is your team leader. So you will be sharing 16 beds. This is how many beds they have in that unit, but again, every palliative care unit in each hospital is different. In my hospital, it's only 16 beds, and it was shared between 2 nurses, so each nurse would take 8 patients. So you will take a handover of these patients and you will give the handover of these patients. However, your team leader and your other nurse will be helping you with all manual handling, with all DD administration and other medications, and even the progress notes. So you work as a team, which is really great, and that load that might seem very high, like 8 patients per 1 person per 1 nurse, is not that bad in the end of the day. Okay, so that would be your ratios. In aged cares, ratios are different according to different aged cares. Where I'm working in the morning and afternoon, my ratio is 36 residents per 1 nurse. I don't have a EN to help me because each floor where I work in a building, it's a pretty big building where I work, it's 4 floors. Each floor has 36 rooms, which means 36 residents. Sometimes some of the rooms would have couples, so your increased number of residents might be like to 40. Okay, so you as a registered nurse will be administering medications to all these 36 residents. You will be doing your wound cares to all these 36 residents, and if you do need a DD check, then you will either ask a different nurse from a different floor, it could be EN or RN, whoever is on a shift, to do your injections, to do your insulin checks, to do your DDs like S4 and S8s together. We don't have any IVs in a aged care where I work. Sometimes we do have carers who are medication administration competent. We call them medcoms. So they may take half of your load. If there is a medcom on a ward, on a shift, on a floor, then they usually take half of 36 residents. And usually the floor is divided into 2 wings. So the medcom will take 1 wing for you and do your morning, your 12 o'clock and your midday 2 o'clock medications for you. They won't be able to do any injections, any insulin administration, any anticoagulants like your warfarin. They won't be able to do that. The only medication that they can administer is from the roll. You know, your medication roll. I'll try to find for you a picture and maybe put it somewhere here in the corner. So that's the only thing that they can do. Any dispensable medications from the boxes, bottles, vials, they can't touch. Okay, so that would be your ratio in aged care for AM and PM shift. Then the night is quite crazy because all 4 floors, and also we have a lockup unit which is on a separate separate wing in a whole facility. It's on the 1st floor as well, but it kind of like just separately by itself. It has only 19 beds there, 19 to 20 beds. So you have like your 4 floors plus a lockup unit. So at night you will only have 1 registered nurse and 1 EN for the whole facility, which is super crazy. I never do night shifts in aged care. Not just because of that, but also because working for Queensland Health, I already have my regular 4 night shifts every month, so that's pretty much enough for me. Like I do 2 nights in a row every fortnight, which completes my 4 shifts, night shifts a month. So I don't really need to pick up more night shifts anywhere else because that's enough for my body. So that's your ratios, okay, for these 3 different shifts for 2 different places. Then let's talk about penalty rates, okay? Penalty rates differ from where you work. For example, let's start with Queensland Health. Your morning shifts have no penalties, okay, because penalty rates for afternoon shifts, they start from, I think now it's 6 p.m. So if you work your morning from, let's say, 7 o'clock or 6 o'clock until 3 o'clock, 3:30, you have just your normal base rate paid to you, okay? And depending where you work, what grade of a nurse you are, your base rate will differ as well. Then on your, and that would be the same to the public sector in Queensland Health and also in aged care facilities. So your morning shifts usually are free of any penalty loads on top of it. But when you start on your PM shift, then you will have 12.5% of penalty rate added to your hourly rate, starting, if not mistaken, from 6 p.m. and onwards, okay? So you will have, let's say, $30 your hourly rate. On the top of that, you will be paid for each hour of your work 12.5. And then from 12 o'clock at night, okay, usually we have our night shift load, okay, but your PM shift will be finished at 11. So you will have roughly from 6 p.m. to 11 p.m. for every single hour you work, 12.5% paid on the top of it as the evening penalty rate. Then your night. So Anything from 12 o'clock of midnight until morning will be paid to you as a 20% of a night shift load. And this is the same for Queensland Health and for aged care where I work, for example. So it's 20%. Same was the same with the afternoon load as well. 12.5, it's for both sectors, would be the same. If your night shift fell in Saturday, for example, or a Sunday pay, then they're not gonna pay you afternoon loads or night loads, because they will pay you instead the highest penalty rate, which would be your Saturday penalty rate or a Sunday penalty rate. Saturday penalty rate is 50% on top of your each hour. Sunday rate, however, is different. For aged cares now, it's not approved yet to be double, whereas for Queensland Health, it's been approved for us to have a double pay for Sunday shifts. But for aged care, they still have it as 75% on the top of your normal hourly rate, which is still really good pay, like really good pay. So fingers crossed that maybe one day the aged care sector will be approved for a double Sunday as well, because that would be really nice. It's a really good money. So if your PM shift or your night shift fell in on weekends, on a weekend days, then you will be only paid Saturday load and Sunday load. As I said, they can't pay you 2 loads at the same time. It's too much. Okay, so that's your penalty rates for 3 different shifts. If you are working mornings and this morning fell onto Sunday or Saturday, then you will be paid your weekend penalty rate. Either it's a 50% if it's a Saturday, or a double if it's Sunday, or a 75 if it's Sunday in aged care. Okay, now let's talk about tasks. In your morning shift, if you're working in public sector for Queensland Health, like just your normal hospitals, you will be doing a lot of manual handling, because a lot of people in the morning, from morning I would say up until lunchtime, like to have showers. So you will have only 1 AN on a ward. My ward, we have 34 beds. Okay, and usually we have ANs only on the morning shifts. We don't have them afternoons. I don't know why, because we do sometimes have showers afternoons. We have lots of continent aids changing, we have a lot of manual handling, moving and all of that, and we do really need ANs at evening shifts too, but we don't have them. So your AN only will come on a morning shift, okay? And most of the people, most of the patients would want to have showers. So that adds a lot of load to your morning shift, because on the top of the personal hygiene that you need to assist your patients with, you have your morning rounds of medications, which will have injections, lots of IVs, because on my ward, it's a general medicine ward. We have a lot of different infections coming through, your UTIs, your sepsis, your pneumonias. So a lot of people will be treated on IV antibiotics as a start to settle down the infection. And prepping antibiotics, it's a double time of what you would spend in prepping your normal oral medications, because you need to prep the medication. It's a liquid medication, you need to mix it, you need to run your line, you need to find a nurse to come and do a check with you and stand with you while you're prepping all of that. So you need to take her out of whatever she is doing or he is doing, your body nurse, and bring them into the bring them into the med room and do the preparation of that particular drug. So that takes time, and a lot of people have a lot of medications to be given in the morning, especially if it's your elderly patient. They have like a whole bunch of tablets you need to give them, and can you imagine if on the top of that they have injections, they have like insulins, you need to check your BGLs, and then you have to give them like IV medications as well. That makes your shift very busy. Then apart from that, you have your dressings. You need to change your dressings, and usually we try to change the dressings during the morning shift. Why? Because we have doctors on board if they need to check the wound, depending on what complexity is the wound. If it's some kind of abscesses, then the doctors need to see it. Also, if it's like chronic wounds for someone who have diabetes, usually there is a wound nurse involved, and sometimes they need to come and have a look at it. So it's better if when they come and have a look at it, you undress the dressing, let them take pictures, let them investigate it, assess it, whatever, and then you do another dressing. Because if you redress the wound and then the nurse will come, the wound nurse or the doctor will come and just like strip the whole thing and have a look at it, and then you have to do it again, that's just a double work. You're doing double work. So again, that adds a load to your shift as well. Then you need to do a lot of transfers. Physios will encourage your patients to be out of bed for breakfast. They will encourage them to be out of bed for lunch, but they won't want them to sit on a chair for too long at the same time, especially if it's someone elderly and prone to pressure injury developments. If they're like skinny in a body type, sitting on a chair for more than 3 hours are not really good for their sacrum as well. We don't have that special cushions that aged cares use sometimes because they are so expensive. Not everyone can afford it, and we don't provide them in our hospital as well. So you will need to move patients for breakfast, then move them back to bed. Usually they like to have a nap. Then you move the patient again to the chair for lunch and boom them back again. You will have a lot of people with different mobility. Some would be just a stand transfer, and you can just be one person there for them to move them from bed to the chair. And then you will have people who are on a Sarah steady, on a standing hoist, on a full hoist. That takes like double to triple time to move different type of mobility patients out of bed. But again, it adds load to your shift a lot. Then you have your 12 o'clock medications. A lot of them would have like some sort of IV or furosemide. That would be your Lasix. You will have a lot of people on drains. You will have a lot of people who would have an IDC, sometimes on an hourly monitoring. So you will need to do a lot of documentation. You need to not to forget to check it every hour, you know. So all of this has a lot of load in the morning, and I feel that the morning shifts are the most busiest ones, but sometimes the night ones can be very hectic too. Then also you will need to liaise with the doctors, because any matter that is arising throughout the morning shift, you want to tackle it in with the doctors on a morning shift, because the teams, they leave by 4 o'clock, and some residents leave even earlier, and then the ward call who replaces them, it's like a general doctor who just goes into many different wards in a hospital. I think in my hospital, like, we have only 2 ward calls per shift, and they cover multiple floors, and they're just like a general doctors. They might belong to a particular team, which could be a respiratory team or oncology team during their normal morning rounds, but when they take a shift of a ward call doctor, they more like a general doctor. They're not gonna get involved too much in some like detailed issues about particular patient, unless it's like a medcom or something like change the dose of a particular medication just for that night, or withhold something. But anything else, they would say just wait for the team to come in the morning, and they will review and do like more in-depth changes. So you as a nurse, when something arises, like any problem, any issue for the patient, you want to make sure that you fix that matter with the appropriate team who is assigned for that patient during your morning shift, while all the team members are still there. Okay, so again, that adds just a load to your shift, because you need to call the doctor. Then sometimes doctor, you call them, they were like, oh yeah, we're coming, never come. You have to follow up again, you know, like you need to keep it in mind as well. And then you will have your 2 o'clock medications. 2 o'clock usually don't have much of IVs, pretty much it's your oral medications like your Panadol and all of that. So they're easy, and then you will need to do another continent 8 changes before the PM shift comes, okay? So then you would have your PM shift. Okay, on your PM shift you will start from the OBS, then you will have your first medication round starting from 8 o'clock. You will have some of the small medication administrations like 4 o'clock or 6 o'clock. Again, that would be your Panadol, sometimes some of your subcut anticoagulants like your Claxanes. But most of majority of your medications will be started at 8 o'clock. In my hospital, we start medication rounds 1 hour earlier. So if it's your, let's say, 8 o'clock medication round in the morning, you will start it at 7 right after the handover. If it's your 12 o'clock, you will start giving 12 o'clocks at 11 while you're doing OBS. And then your 2 o'clock you start at 1, and then your 8 o'clock at night you start at 7 while you're doing your second set of OBS. So you're checking the OBS, you're making sure that the blood pressure is fine, the heart rate is fine, to give any antihypertensive or any heart medication, not to lower it more down. So you do it all together. So to me, the PMs, they are more cruisier. You don't really have a lot of showers. Most of the dressings are done already by the morning shifts. You will still need to do obviously your OBS, which in my ward we mostly have them every 4 hours. Some people who snap to the maintenance would be like once a day or once a shift every 8 hours, let's say. Then you do your 8 o'clock medication round, and then you will have a couple of BGLs at 9 o'clock and your insulin administration, and you might have your IV antibiotics at 10, which you will be starting at 9. So as I said, to me, PM shifts, they're more cruisier. Okay, the only issue that I find difficult is with demented patients who have sundowning. This is when you need to keep an eye on that patient, because sometimes you have someone coming, for example, from a nursing home with the UTI, okay, and that patient is purely for treatment of their UTI. And you might find in the history, in the medical history, that the patient has, let's say, delirium and dementia on a background. But some people prone to the sundowns, some people not. Some people with dementia might just sleep throughout the whole shift. And some people, because they have dementia, they see that they are in unfamiliar place, so the whole hospital looks different to them. It doesn't look like their aged care facility. So that just adds a lot of anxiety and stress. They don't have familiar faces of the carers or the family members who used to maybe come and look after them in an aged care facility. All the nurses are new people to them, strangers, obviously, doctors and everyone. So they become very anxious and agitated. And also when the sundowning starts, you know, they start to wander. And if they are elderly people, a lot of them are on a high falls risk. So you will need to monitor those patients. And if it's a new patient who came with UTI, you don't know how their dementia will be like progressing or acting throughout your PM shift if it's a new patient, you know. So sometimes you might, as I said, have someone who will be sleeping through the evening and night. And sometimes dementia will kick in, the sundown starts, and you were like, oh, cool, right. So let's order CPO for the night shift, making sure that the other nurses during the night shift will be able to look after other patients, because the ratios are higher during the night shift. So that particular patient who is a wanderer, high falls risk, has a sundowning, will have a CPO. CPO, usually it's one of the AANs who would come and just literally one-on-one sit with that patient throughout the shift, making sure that that patient is safe. Usually they can do the pad changing. They won't be administering any medication to that patient. They would be just purely sitting there, redirecting patient to the bed, maybe talking to them, maybe like watching a movie together, you know, or whatever, just making sure that that person is safe and not gonna have any falls or wander out of the ward and get lost somewhere. Because we as nurses, we can't keep an eye on all our patients. It's just impossible. We go to the pen room, we go to the medication room, we prep medications, we get busy with different patients. Like, you know, it's just impossible to be there always for a particular patient. So that's the only challenging thing that I find in PM shifts. Someone who have dementia, they might be a little bit challenging for us as nurses, but most of the time PM shifts for me are much easier. We don't have a lot of activity happening. We don't have a lot of like imaging. Sending people for different type of scans. We don't have procedures scheduled for evenings. We don't have like iron or blood infusions, transfusions during the PM shifts. It's like pretty cruisy. Then your night shifts, I find them different. Like every night can be different. Okay, again, if it's someone who has dementia, we might just administer some medications to settle that person and help them to sleep. Like that would be your diazepam, temazepam, and all similar medications to that. You will need to see if the doctor can prescribe for them something like that so they could sleep easier. Sometimes you might have someone who would be med calling, and I find that most of the med calls, they happen from 4 o'clock in the morning when people start to wake up a little bit more, and sometimes the deterioration starts as well. So like most of the med calls that I have observed for the past 2 years working for my ward were between 4 o'clock and the end of the night shift, like between 4 to 7. And we also had even people passing away just before the handover when the morning staff come. But generally night shift, if you have patients who are not heavy medically, who are stable, they will usually sleep through the night fine. You will just need to do your like midnight doses of antibiotics. Some people would be on 12 o'clock midnight doses of IV antibiotics. That would be pretty much it. Some of the patients would ask you to give them some PRN analgesias. Some people would need assistance to take them to toilets, and maybe pad changing for those, not maybe, but you will do pad changes for people who are bed-bounded. That's about it. So it's just depending. Sometimes your night shifts can be a little bit hectic if you have a heavy load of patients, but usually for me personally, I love my afternoons the most. I'm not even big of a morning person when it comes to work. If I know that I'm not working, I will wake up like 5 or 6 in the morning. I love my walking. If you are following me on my Instagram, you probably see me in my stories always either climbing mountains or going for a walk near the water or just hiking or whatever. I love my morning walks. I would wake up for that really early, but if my body knows that it's a morning shift, I'm very hard to wake up and go for a morning shift. I feel really energized and like happy when I finish morning shift because it ends really early during the daytime and you have like half of the day still to go. But personally, like when it comes to waking up in the morning, I prefer afternoons to go to work. I like to sleep in, I like to wake up, go for a walk, have a drink, have a breakfast, whatever, do all my stuff and then go more energized and even have a nap before going to my PM shift. Now, in your aged care facility, it will be kind of similar in terms of your tasks, it's just the load will be different, okay? So your morning, you will have same pretty much times for your morning medications. So your AM shift will have your DDs first. So you will start your shift by giving DDs, which means your S4 and S8s. So all your analgesia and calming pills you will be given in the morning. And then you will start your 8 o'clock medications, which also will include your BGLs checks and insulin. Then you will have your 12 o'clock rounds, and then you will have your 2 o'clock rounds, and that would be the end of your morning shift. You will finish most of your dressings or try to finish them during your AM shift, and also you will liaise a lot with your doctors. So a lot of GPs, they love to come in the first part of the day. So you as a nurse, you will need to update them on a medication changes for the patients, for the residents. For example, someone has been changed on risperidone. If someone has or had high levels of agitation, we can't put on a high doses of risperidone our residents because this will increase a false risk for them because they're elderly, and risperidones, they can give that effect of sleepiness. So if someone has been agitated and the doctor, let's say a week ago, came and changed the dose of risperidone, just increasing it a little bit, you need to let the doctor know how the patient, how the resident has been going throughout the week. And see whether maybe the dose can be either increased or decreased a little bit to find that sweet middle, to make sure that the person is safe on their feet, but yet is calm and happy and less agitated. Because when people are agitated, they might harm themselves, and also they might harm health workers as well, and we don't want any of this to happen. So for the doctor, it's very beneficial to speak to you as a nurse, take them through all the charts and everything, because usually they don't find anything by themselves. It's like they're just clueless when they come to us, so we have to help them and just direct them, and then they will make appropriate decisions together with us according to what information we'll have provided for them, you know, during that monitoring period, to either adjust the doses or leave it as it is. So you will spend quite a lot of time with doctors. Doctors don't come every day, they come like 3 to 4 times a day. Each resident will have a different doctor. Some doctors will be covering like 60 residents in a facility. Some doctors will only take 20 residents in a facility, and that particular doctor might come twice a week or once a week. Okay, then your dressings is not the same as in a hospital. In hospital, when we do a dressing change, we do not take photos, we do not upload anything into the system. In my ward where I work, everything is a paper-based. So we have a wound care management plan where I will update that today the dressing has been changed, you know, the layers of the wound, dressing type and all of that, and put if there is any pain score, you know, if the patient had a pain, any odor or any discharge. I will just tick pretty much boxes, and that paper chart will be in your blue chart of a patient. I don't have to take photos, as I said, go to the computer, upload anything, which adds more time to my tests. But in aged care facility, it's completely different story. We usually don't have wound nurses on site. We do have wound nurses who we can refer to the resident if there is something really complex to me as a registered nurse or to the CN that we have on site. Then I can refer it further to a specialist, like a wound nurse specialist. But in general, most of our wounds are done by us, by registered nurses. And how the process of wound happens is, you take the work phone, which you will be using to take photos. You will take your paper chart, see which wound needs to be changed today, and then the process of what type of dressing, what type of cleansing agent, what type of packing agent, whatever you use. And then according to that, you would go to each particular resident who needs the wound to be changed, and you will do the change. You will take a photo. Then when all the wounds allocated for that day has been done by you, you go back to the computer and you've put all of these updates into the charts in a system. Okay, usually my wounds, they take about an hour to complete, and I might have ranging from 10 wounds to about 20 wounds a day. Every wound is different. Some would be just easy, not even dressed wounds that I just need to take a photo and simply update it in a system. Some would need a lot of work to be done to cleanse it, pack it, soak it, whatever, redress it. And then it takes me about half an hour to put everything in the system, sometimes even to 40 minutes, because in between while you're doing, you have carers calling you, hey, someone had a fall, you have doctors calling you, you have pathology calling you, you know, you have family members calling you, asking you, update them on their dad or mom, if they've been eating, if they've been fine, if someone had a fall yesterday, how they going. So you get interrupted a lot of times, and I feel like interruption happens more often and on a higher level in aged care than in a hospital, because of what I just have mentioned. So yeah, so that just takes a lot of time when it comes to wounds when you do it in aged care facility. Yeah, so I've lost my I've lost my thought now where I was going with that. Yeah, I think I was talking about how difficult load wise are the shifts in between two different places. Yeah, so in aged care facility I find that the morning shifts are very busy as well, as in a hospital, even more because of what I have just mentioned. Then you will have a lot of admissions as well in both places. In aged care, CNs will be helping you to do admissions because aged care load is heavier in general. So CNs will take some part of admission on themselves, but in a hospital you will be doing admission by yourself. If it's an internal transfer from different ward to your ward, it's fine. The admission will be already done by the first ward where the patient has been transferred from ED. But if you do have a patient from ED, then you will need to do your admission from scratch. So that would be your presentation on admission papers, your falls risk, pressure injuries forms, if someone is smoking, you know, your BGL forms and all of that. So your cannula, your IVC form, you will have all these forms that you will need to do by yourself. And if you have time, we try always to do it on my shift before I hand it over anything to the PM shift. I try not to add a load to the other shift. However, most of the TLs and the hospital coordinators always say that it's a 24/7 cares. You're not a superhero. You don't have to complete everything throughout your shift. You can hand over the load to the PM shift, but we always try to like do as much as we can and hand over less. Then PM shifts in aged care, I would say they are easier, same as in hospitals. You would start your shift, and if any dressings have been deferred to you from the morning shift, then you will do it in the first 2 hours, because when you start your shift at 2:15 or 2:30, you don't really have any medications to be administered until about lunchtime, which is your 5 o'clock, which you will start at 4, an hour earlier. So it works exactly the same way as at the hospital, because you have a lot of medication to administer, so you want to start an hour earlier. So you will have that kind of like a window between the after the handover and your dinner round. Did I say lunch? I meant dinner. Your dinner 5 o'clock round. So you will have that window. So if you've been handed over any dressings, you would try to knock it off during that time, and then at 4 o'clock you will start to prep your dinner medication round. Then you will have your DDs. Right after dinner, you will have your DDs like your tapentadol, your Targins, your endones that will be covering the patients through the night. And then at 7 o'clock, you will start your 8 o'clock medication round. And then after all of that, you will be doing your progress notes and ending your shift. So as you can see, you don't have to interact with any doctors on your PM shifts. CNs are not there, management will be not there. After like 4 or 5 o'clock, they will all go home. So you're purely dealing just with the residents. If you do have falls, or you had falls in the morning, you might have your after hours doctors coming in to check the residents, making sure that they are fine, maybe chart some of the medications. If you notice that someone was showing some signs of UTI, so the morning nurse would book an after hour doctor to come and chart antibiotics and assess the resident. But usually after hour doctors, they come at evenings. They usually come like anytime after 6 o'clock and onwards. And you as a nurse will need to deal with those doctors, but they don't come every day, and if they come for just one particular resident on your floor. So your time of dealing with the doctor will be like maximum 10 to 15 minutes, if not less, and then they move on to a different resident on a different floor. So yeah, I always find that the PM shifts, they are less hectic in HK as well. I can't tell anything about the night shifts in HK because I haven't done them, and I'm not looking forward to do that. But I can only tell you about the ratios, which I have already mentioned. Most of the nurses will be doing as well rostering for the next day. So for example, if someone who is rostered to work next morning, whether it's a nurse or a carer or a kitchen person, have called sick, so the night nurse usually is responsible to replace that person for the upcoming morning shift. They can either call all the carers from the list who work in a company, you know, offering them an extra shift, they will be sending notification by text messages to everyone, or if nobody is responding a couple of hours before the actual shift starts in the morning, they will take someone from the agency. They try not to take agencies as a first priority because they have to pay them more. So then try to allocate the shifts throughout, like the permanent staff, then casual staff like me, and then the agency, because it goes like pay higher, you know, every time you go like from a permanent to casual and then to the agency. So they save money obviously and give it to the permanent first. Yeah, and then they will print out all the handovers for everyone, you know, allocations and all of that. So they do a lot of printing work. Then they will do the DD's checks. So that's why your RN, she needs another nurse on a shift. But again, maybe it's a payment reason why they don't want to take another RN to work together at night, why it has to be EN. But most of the time in my aged care facility, it's one EN and one RN. But when it comes to DD's checks during the night time, EN and RN can do it together. So we'll be administering all the DDs. And then if someone has been sent to the hospital after a fall, so they will be accepting that resident back throughout the night if the hospital send them back. If any falls throughout the night, they will be contacting radar, getting advice, sending them to the hospital as well. So that's all what I know about night shifts at the aged care. Again, because I don't do them, so I know only a little bit. But I hope this video was helpful for you guys. I tried to cover the most asked questions by you in a comment section under my videos. A lot of you ask about ratio, which shift is better to pick, the payment rates as well, and also the times when the shift starts, because a lot of people who follow me on YouTube are mothers who have small kids, and they always want to know before they start studying for nursing whether they will be able to do morning shifts and be able to put their kids into early birds, you know, in an aged care, in childcare, or early bird in a school or after school care or whatever, so they could start and complete the shift and then have that a little bit of time to pick up their kids as well. So I hope I covered all of that. If you work for Queensland Health though, I just want to mention really quickly, you won't have a lot of control over your shifts, especially when you just starting nurse, finishing your grad year. You know, on the wards like a surgical wards, medical wards, you will be doing rotation of different shifts. Like on my wards, we all have 4 shifts at 4 night shifts, because to be fair to everyone, somebody has to do night shifts, so we just spread them equally to everyone. So most of us would have 4 night shifts every single month, and then we will have different amounts of AMs and PMs. There are no fixed numbers how many AM or PM shifts you will be getting every fortnight. But every month we would have a different roster. So every month I would be working different days throughout the weeks. Each month of my work will never be the same as my previous months, okay? So I will be always rotating between different shifts, between different days. The only thing that will be stable is my contract in terms of how many shifts I am doing every fortnight. At the moment I'm doing 7 shifts a fortnight. Sometimes I ask my NUM to put me 8 shifts a fortnight, like for example this month I'm working 8 shifts a fortnight. But because you do a lot of rotations between the shifts and you have different payment loads as well, for me 8 is pretty much enough. I get tired as well because I swap between mornings, afternoons and nights, so my body gets tired, so I need rest. So in a nursing career it's really hard to do full time because of this reason, because you do a lot of shift work, but also because you have good penalty rates. For most of the people, 7 to 8 shifts a fortnight is enough money to live and have a comfortable life, pay bills, you know, travel as well. And every year you grow in your career, in your experience, they add it on to your pay as well. They increase your pay, which I find it fair, because you learn more, you can do more, you become more safer and more knowledgeable clinician. So yeah, so that's about your shifts. So you won't be really choosing a lot. But if you work in aged care, you might have an agreement with the managers to put you only on AM shifts, and you might have only AM shifts, like maybe 4-6 shifts a fortnight, and then maybe only 2 PMs. This is how I had it before. I had majority of my shifts. I had like 6 shifts, I think it was AMs, and only 2 PMs. I never done night. I told them from the beginning I did not want to do night, and in HK is fine. They can't force you to do nights. It's not a public sector. They can't. Okay, you can negotiate and you can discuss with them what shifts you prefer to do, and if they do have them, they will give it to you, or you can put yourself on a waiting list, because turnover in aged care is very high. A lot of people go there as a transitional place after graduation to gather 1 year of experience and then move on to your clinical areas. Or you will have people going into aged cares who've been working in a clinical area for a long time. It's very hectic for them. They don't want to run the floor anymore. They want a little bit of peace and mind. They go as CNs to aged care as well. Sometimes normal RNs as well. Although I can't promise that it will be less hectic, to be honest, but you will see a lot of elderly nurses end up in aged care for a peace of mind, and this is what they say. But to me, it looks hectic either way. But yeah, so you can have an agreement with your management and see what shifts you want to have as a priority, as a like the biggest amount between what you have. Yeah, and then just work your way up and just see if anyone leaving, as I said, you can pick up their shifts and maybe end up having only PMs or only AMs, whatever works best. In aged care, they want to keep everyone because we are so short staff, then they are willing to negotiate with you in order to keep you as a staff, so they could have someone looking after the residents, because aged care at the end of the day is very good income business, like income wise business. So it's important for them to have staff to care for the residents, because if there are no residents, there is no income. Okay, so if you have any questions, please feel free to leave them in the comment sections below. If I haven't covered something, then let me know and I can record it in the next videos. Thank you for supporting me on my channel. Thank you for being with me from day one and being such a great emotional support for me, guys, through my Instagram. I have a lot of you DMing me there as well, asking questions and just sending words of appreciation for the information that I provide in my videos. That just encourages me to create even more content for you. So I read all your comments and I want to say a big thank you to all of you guys, and I will see you in my next videos. Bye.